and the pleura starts ballooning, okay, and it makes your dissection more difficult. So if there's a small pleural rent, it is better to suture, okay. And if it is a large pleural rent, it is better to open it and go transpleurally straight away, okay.
Yes.
And risk. But a small tip, when there's a small opening in the pleura, is you can't suture it directly, as you rightly said, okay. So the other technique that is being used by some surgeons is they take a stitch of the pleura with the lung, so that actually the pleura gets stuck to the lung at that area, so that there is a there's a little strength to the suture. Otherwise you can't suture. As you rightly said, if you try to suture the pleura, it keeps tearing. So suture it along with the underlying lung, so that at least the rent doesn't spread further. Sir, at any stage, Ramchandra, Kiran, Raju Sauji sir, Gopal Pingali, whoever is there, are free to add.
No, I just wanted the PGs to reflect upon why it is done extrapleurally. What are the various reasons? I just want them to reflect upon that. It is not just the vanity of having discovered a new technique by pediatric surgeons that it is handed over from generation to generation. There are definite advantages of staying extrapleurally, and the PGs need to reflect upon that, why it is done and why it is so important. And you will understand it more, clearly when you see, when you try to do a tracheoesophageal atresia TEF repair transpleurally. How difficult and how messy it is when you do it that way. It is not impossible to do. It is quite easy to do it, but it is not a very nice thing to do. And what are the other things which help a surgeon look after a patient with the esophageal atresia, tracheal fistula post-operatively? If you have done completely extrapleurally and you have stuck to the principle of being extrapleural throughout. So the PGs need to reflect upon that and need to identify the advantages and keep that in their mind and use it for their future when they are practicing.
So one advantage is like if you go extrapleural and if there is any leak, minor leak, then because of leak there might be empyema formation. So if we go transpleural, if we go extrapleural.
Yes, correct. Yeah.
Not just empyema, even if there's a small leak in the extrapleural space, if it is contained, it becomes like a controlled fistula. Okay. Whereas it is going to be only salivary fistula. Whereas if it is going to be going inside the pleura, the chances of infection, sepsis, and everything increases.
And also, when you are operating transpleurally, you will realize that to reach the posterior mediastinum, you need to completely collapse the lung and retract it with proper retractors. Whereas here, the pleura acts as your retractor largely, and the anesthetist need not struggle too much when you are doing a extrapleural repair. That is one of the major advantages of staying extrapleural.
Come again, sir?
If you go intrapleurally, the lung will come in your way especially when you're going towards the posterior mediastinum, where most of your work is. So it is easier to stay extrapleural, and you can do your business part of your operation very easily. If you are intrapleural, to keep the lung collapsed and retracted to reach the posterior mediastinum, the anesthetist really needs to struggle with the ventilation. That is what I have found.
Okay, sir. Good point. Next thing about the fistula ligation. What are the pros and cons of fistula ligation? Are you just going to ligate it or suture it? Because there are two techniques.
Better to suture it.
Can you elaborate? When you say suture, what do you mean by suture? I mean, what is commonly done? What are the other alternative which can be done? What are the potential advantages, disadvantages, both of them?
It can be done like both the first the fistula should be tied at both the end, and then suturing can be done either with the
purpose is lost.
Sir?
If you tie it both the ends and then suture it, the purpose is lost. Okay.
Not both the ends, sir. I mean to say that once we cut on the inferior end and upper end of the fistula at the tracheal ends.
Understand, at tracheal end, most of us actually end up doing transfixation and ligation and division. Okay, as close to the trachea as possible, but as you rightly said, not including the trachea. Okay, even very small stump, millimeter length, and do it is one option. But the disadvantage of this is, if we just ligate it, transfix it, ligate it, what can happen? Potentially.
Particular fistula will reopen, might reopen. Sir.
That is because of
The air pressure during ventilation.
more than that. More than that.
Aortic stenosis and
No.
tracheomalacia.
No. What happens is, theoretically, if you're going to just simply transfix ligate it, there's a possibility there can be ischemia and it can slough off, and that can lead to the fistula. So the Puritans of the surgery, especially Ashley and all, used to insist that actually you divide it and you have a continuous suture over the fistula so that it is securely closed without any chance of ischemic injury. Okay, this is other option, but most of us actually don't do it because we manage to, if you don't tie it too tight, okay, if you're going to tie the suture firmly and not too tightly, it should be okay. I thought you didn't tell much about the difficult and easier parts of the dissection of the upper pouch and the lower pouch. Can you just tell us a little more about it? So what are the difficulties that you will face when you are dissecting the upper pouch, and what are the precautions that you have to take when you are dissecting the lower pouch?
So while dissecting lower pouch, the segmental blood supply needs to be preserved, and vagus nerve need to be preserved. It should be mobilized meticulously because there are less segmental blood supplies. If it is hampered, then again lower esophageal pouch will be having ischemic changes.
Okay,
Whereas
what about the pouch?
upper pouch has got rich blood supply.
From where?
So
What is
from
the blood supply of the upper pouch?
from the aorta, sir. Direct branch of
From upper pouch, what is the blood supply of the upper pouch?
one direct branch from the aorta.
Ultimately, we all get blood from the heart and the aorta. So ultimately, it comes from the heart and the aorta. So your answer will be technically correct.
Actually, yesterday Ashchit told this point very highly. I mean, he highlighted this point.
Inferior thyroid arteries.
Correct. It is applied by inferior thyroid artery. That is why the upper pouch can be mobilized till kingdom come. You can mobilize it up to the upper portion. As much as you can. You can even go up to the neck from the chest if it is possible. All right.
See, you have to describe the unique characteristics of the vascular supply of the upper pouch. So you have to tell that the vascular supply of the upper pouch is very robust and it is high up in the neck and it is coming from the inferior thyroid artery. The inferior branch of the inferior thyroid artery, which is a esophageal branch, which is a short branch, which comes into the esophagus, immediately enters the esophagus, the upper pouch esophagus, and then reaches the submucosa and arborizes very, very liberally. So there is a liberal submucosal plexus. So when you are mobilizing the upper pouch from the trachea, you do not encounter any vascular structure at all because the vascularity has already entered and it has richly vascularized the upper pouch. So all these things you must keep in mind and you must tell when you are answering in the exam. And that is also the rationale for doing levaditis, circular myotomy, or the spiral myotomy with suturing, which was later described as an alternative to levaditis myotomy. So there you stay away from the submucosa and cut the muscularis so that the esophagus gets elongated. So one cut will elongate the esophagus by around 0.5 to 1 centimeter. That's what they say. Okay, so this vascular supply of the upper esophagus has to be kept in mind. Very, very, all detail. You have to keep it in mind, and you have to immediately blurt out the answer. The examiner will be very happy, and also in your real life, you must know what you are doing when you are mobilizing the upper esophageal pouch. Okay.
Yes, sir.
Okay. Next question is, when you're dissecting the upper pouch, which part of it is easier, which part of it is difficult, and what precautions you take?
So low distalmost part is easier to mobilize, but uppermost part it is as it is nearly approximate towards the trachea. So
Are you sure?
No, the tracheal parts, the tracheal end, I mean the surface, the medial one, is difficult because they share almost a common wall. So while dissecting, more chances of causing a rent in the trachea. So there we have to
Okay.
be careful.
Okay, it's a common wall between the trachea and the esophagus in the lower part. In the upper part, it is much easier. Okay. Distally, it is more difficult. So what is how do you actually do the dissection distally and then proximally?
So we can encircle the upper pouch proximally and start dissecting from.
Okay, okay. You come to the alternative technique. We'll come to that later. But what is a commonly described technique in open surgery? Same thing in thoracoscopy also, by the way. The standard technique. Anybody? I think all of you have done TOFs, no? How do you start the dissection on the medial wall? Hello?
Sharp dissection.
Sharp dissection. Okay. You need to apply traction sutures on the proximal pouch, distract it away from the trachea. And if you're using a magnifying loupe, you'll be able to see some sort of fibers between the two. You need to make a sharp dissection. You need to take a sharp scissors and start the initial dissection with the sharp dissection and gradually sort of divide the esophagus and the trachea, separate them. The initial part is, especially the lower halves to 1 centimeter, is going to be very tough, and later on you will be able to get a little more plain. Okay, this is a place where traction is going to help, magnification is going to help, and your sharpness of dissection is going to help in making sure that you don't open the trachea. Between the two, obviously, you're going to stay more on the side of the esophagus than on the trachea to avoid a puncture. Okay. Once you dissect the lower half to 1 centimeter, the upper dissection is much more easier. It is something like our rectovestibular fistula, a common wall between the rectum and the vagina. Okay. The initial portion is difficult, but after you dissect a little bit, then it becomes a little easier. To alternate this, I think, which surgeon is that? The Dutch surgeon, I forgot his name. Thoracoscopy. What he started doing is what Shoaib was trying to tell. That is, go higher up, where the dissection is actually there's a better plane between the trachea and the esophagus. Loop it down and then dissect it from above downwards. But that is not feasible in many cases. Maybe it's feasible in a handful of cases.
So is that Wandersee?
Yes, sir. You're right, sir.
Wandersee?
Wandersee, sir. Wandersee.
Okay.
Well, of course, according to him, I heard him speak. He says it is possible in all the cases, but somehow I don't believe that it is possible in all cases, because after listening to him, I did try it, whether it is open or thoracoscopy. In some cases, it is feasible, but in many cases, it is not feasible, sir. Okay. When you're placing the extrapleural drainage, is it the ICD you said? Is it ICD or extrapleural drainage?
Extrapleural drainage.
Okay, it's an extrapleural drainage. So it depends on what you're going to keep, because many times the NICU people think it is actually a transpleural drainage. Okay, it is not. It is not an intercostal drainage. It's an extrapleural drainage. To that extent, in our institute for a long time, following Dr. Srimurthy sir, we never used to even place a tube drain. What we used to place is to place a glove drain in the extrapleural space, and that is sufficient, because if there is a leak, the leak comes out through a glove drain and it becomes like a salivary fistula. And it is a controlled salivary fistula. A minor leaks definitely certainly will heal just with passage of time with additional support. Okay. Whereas if you keep a tube drainage, advantage is that, of course, it drains a little saliva. You will be able to monitor how much of it is coming out and take it. That's the reason for which, in case there's a leak post-operatively, and or rather, the earliest indication of a leak is pneumothorax.
Pneumothorax.
That's why I'm saying, say, if there's a pneumothorax happening, please understand that the drain that you have placed is in extrapleural space, not in the pleural space. So your ICD may not be sufficient. You may have to think, if it is not enough, you may have to put one more drainage just for that sake, because pneumothorax is going to drain the pleural space, and your drain, what you have kept, is in the extrapleural space. Am I right? Am I clear?
Yes, sir.
Of course, at every level, I want any seniors to put in any suggestions that you want. I mean, these are my points that I wanted to add. What are the predictors of long gap? Because preoperatively, when you go inside, you need to counsel the parents. Incidentally, you didn't talk anything about counseling at all. So when you're going to operate a child with the TOF, you're going to counsel the parents. What are the things that you're going to highlight during counseling?
So one is anastomotic stricture need to be told about.
The long term, no, there's a late term. If stricture happens, that means child has survived. So what are the other things you're going to tell them?
Anastomotic leaks.
Okay, then go ahead with everything. When you're taking a consent, what are you going to take? You're going to not take about just a complication. The complication is later. When you're going to take a consent, what are you taking a consent for? You're taking consent for procedures, right? So what are the procedures for which you will take a consent?
Sir, can I interrupt?
Please, everybody can interrupt.
No, just for the PG's sake, when they're talking about counseling part, it's better to go as a stepwise approach. For example, you have diagnosed the case and taking for a surgery. First, talk about the diagnosis related things and any other possibility of finding during the surgery. Then any intraoperative complication you expect or what you can do it. Then later, how will be the post-operative course and anything expect during the post-operative course. Then early complication, late complication, and overall prognosis. If they think in this order, no, at least 1 or 2 points they can get on all the headings.
Brilliant, Anil. Brilliant. I mean, I really appreciate what you put. I think that's something which is all of us have to inculcate, that you go in a methodical manner about taking a consent. Okay. Now that he talked about it, go about it again.
Sir, intraoperatively, like difficulty in mobilization of the pouches will be there, sir. And
sure, we have to understand one thing. As a layman, the parents are not worried about intraoperative problems, intraoperative complications alone. They are interested, like what Anil said. See, what is the diagnosis?
esophageal atresia with fistula.
Fistula. Okay. So, what are the other comorbidities and what are the chances of primary surgery and what are the chances of what is the risk of the baby? That's what they are interested. So, what are the risks?
Sir?
So what is the risk assessment? You're going to say about risk?
Yes, sir. Yes, sir. We generally will tell the parents about the child's conditions. Right now, we only know that child has a tracheoesophageal fistula. Like there is the esophageal two ends are not there, and then there is a fistula. And we'll tell the weight of the child, and we'll tell them there is a criteria. Our procedure is just a tracheoesophageal anastomosis, but the outcome depends on various other things. One is the surgical gap, and one more is the associated other conditions, weight of the child, any pneumonia, whether the child is on ventilator, whether the child's condition, whether the child is in sepsis, those things. And intraoperatively, how did the child do? I mean, how based on how the child does, that also depends on the outcome. And if the gap is long, then if the gap is small, we will try for primary anastomosis. If the gap is long, then we may think of other alternative procedures like a focus technique, or if it is if we are not comfortable, we would rather go for a esophagostomy and gastrostomy, sir. Feeding gastrostomy.
Okay. Well said, Vinay. Okay, so when you're going to talk to them, you're going to talk to them about associated malformations. You're going to talk about success rate. You're going to talk about surgical alternatives, the risk, the associated malformations, and then, like Anil said, short-term complications and long-term complications. Okay.
Yes, sir. Yes, sir.
Having said that, now preoperatively, are there some factors which will tell you that okay, this case is likely to be difficult because there is a predictor for a long gap, and there's a chance of either for some alternative procedure or a diversion.
One is with the
Indicators for a long gap.
one is if there's if pure esophageal atresia is suspected, then there will be usually long gaps.
Very good. Next,
if like after putting orogastric tube nasogastric tube in the upper pouch, we can assess till where it is there, sir.
Okay. So tell me more. So till what there you say it is a high possibility of long gap.
So if it is above T2 vertebra, then we'll.
Yes. If it is above T2 vertebra, you say it is a long gap. It is T4, it is a good gap. And
Yes.
if around T3 level, it is likely that it can be with a little difficulty it will come. Okay.
Yes.
One. Any other preoperative indicator suggestive for a long gap? I think we have discussed about this.
Spinal anomalies, hemivertebral.
More than spinal anomaly, anything else. In fact, this has come from Gauri's boss.
13th rib.
13 ribs. Okay. So count the pair of ribs. If there are 13 pair of ribs, it generally indicates that the gap is likely to be more. So once that is there, then you can at least, how it is going to alert you? Okay. So what is, okay, if you're suspecting that it can be a long gap, what are the things that you can think of and how will it affect your management or thinking?
Dr. Ramesh, before going, can I add one more point?
Please, everybody. Anil, Gopal,
Yeah, because
Ramchandra sir,
since we are talking about how to judge beforehand this is a long gap or not, I would like to stress that I don't know, it has not probably come up anywhere in the literature yet so far, but what I'm practicing, how can you objectively tell? All these are sort of conjectural things that there is a possibility like that. What I do, otherwise also we are doing bronchoscopy for before the primary repair or otherwise. The advantage of bronchoscopy, another point is that the tracheomalacia which is there, whether it is the anterior wall which is collapsing or the posterior wall which is tenting in, what is known as membranous dyskinesia, is extremely important because right there after the primary repair during thoracotomy or thoracoscopy, you can fix the posterior wall to the perivertebral fascia. The biggest advantage is that the tracheomalacia is taken care of there and there itself by multiple stitches. Second important point, what we were discussing a little while earlier, that if you transfer
again, I lost the conversation. Can you just elaborate again about bronchoscopy?
If you do bronchoscopy, the bronchoscopy will tell you tracheomalacia is because of collapse of the anterior wall or because of the tenting of the posterior wall, membranous wall inside like a tent, what is known as membranous dyskinesia. Okay, so when you have you are using your usual technique of transfixation, ligation of fistula, you have rightly said possibility of ischemia and recurrence of fistula, that also is taken care of, and simultaneously you are taking care of tracheomalacia as well by fixing posterior wall of the trachea to the perivertebral fascia, what is known as tracheophysi. Okay. So that will prevent practically 100% no chance of recurrence of fistula, and if at all very minor chance of anterior wall which is collapsing, that will not be tackled, but at least posterior wall is taken care of by fixing right from say upper bronchial to much higher level above the fistula. You can fix very nicely by 5 or 6 stitches, and you can see the immediate difference in the tracheomalacia and hence airway complications or problems in the post-operative period. Second important point, what I do is I wedge my smallest scope into the fistula. And then I put Hega's dilator fine into the upper pouch of the esophagus. And I ask to take C-arm by C-arm X-ray on table, and you can judge there the length. Once you finish this, you take out your scope and all, and then you see the film, and you see between the two tips how much is the distance, and by that you can very well objectively tell that okay, my fistula is likely going to be 2 centimeter, 4 centimeter, 6 centimeter. I mean gap, sorry, not fistula. Gap is accordingly, and if you know fairly well that gap is say more than 3 centimeter or say up to 3.5 centimeter, I have certain steps to take. But then generally we are able to manage on table by mobilization of upper pouch and lower pouch. Here what I do, when I get such a situation and beforehand information, right there before doing thoracotomy, I open on the right side of the neck and mobilize the upper pouch, taking it up as if we are doing esophagostomy, taking it up, dissecting it up to the cricoid cartilage where the esophagus begins. So you get that additional 1 or 2, 1.5 or up to 2 centimeter sometimes length, and then again put down into the tract, and then make the patient in lateral position and go for usual. So you get additional length of the upper esophagus without myotomy or anything, and with a nice reduced distance. So these are the 2 points which I thought I'll add.
Lovely, Raju. What you said was good food for the thought. Actually, I have not tried any of these. We'll have to try it. Good idea. Good idea.
Yeah.
Vinay Jadhav, Vinay Maximus. I mean, you've been too silent. I mean, you've got
just
a lot of tricks up your sleeve. I know about it. Please tell.
Sir, just one question, sir, to Rajesh Soji, sir. Do you do tracheopexy for all the cases, or do you select it specific?
Yeah, as a routine, because it hardly takes extra 10 minutes. And imagine in the post-operative period, suppose if the patients are developing after discharge, dying spells or the cyanotic spells, you are always worried, and usually one trained to keep diagnosis of gastroesophageal reflux or trachea. And this tracheomalacia is ignored. Or if tracheomalacia is seen also, imagine within first month, you have to again go and do the tracheotomy and do the tracheopexy or whatever procedure you want to do. Or you have to tell to the parents, are you going to do only this and is going to give you 100% success? The second issue comes that if suppose there is associated reflux, you have to do fundoplication also if dying spells are occurring. So if you have done at the time of primary repair tracheopexy, you have already taken care of tracheomalacia. So if at all you have to do in such a dying spell, if the need arises, very rarely you will have to do that is fundoplication.
Good thought, Rajesh. Somehow, but we have not been having so much issues about bronchomalacia or tracheomalacia. We do have it. I'm not saying no, but we seldom had to go inside to do something. Am I right, Vinay Jadhav?
Yes, sir. Most of the time, maybe it depends on how much we have followed them and how our pick rate.
Exactly. Yeah, that's the point.
One more thing, sir. Just wanted to ask to fix a trachea posteriorly, then the trachea requires some mobilization, isn't it, sir, to identify the posterior? Because when we are discussing, most of the time we get the cartilage and the.
What happens is you have already dissected for fistula. It hardly takes 5 minutes. You just put a simple gauze piece and just shove in there. It keeps on creating a plane for you.
Okay. Sir, it will be very interesting if you write a paper on that, sir. We were unaware of this.
Number. I am in private practice. Mostly I do this thing.
Okay. No, very interesting, sir. Very interesting.
It takes some more. I am filing up cases and I am very happy with this thing because you can very confidently answer to parents in a post-operative period. You yourself know that you have taken care of such thing.
Just one more question, sir. You mentioned about opening the neck and mobilizing the esophagus. Have you tried on-table focus also, sir? In few cases, we have done on-table focus. Exact 10 minutes of traction, we actually get length of the esophagus, sir. So have you?
No. What I am talking about is upper pouch mobilization. I am not talking about lower pouch.
Do you have also done a lot of on-table mobilizations of the esophagus, like an on-table focus and then seen the difference? Or,
Okay. No, not really like that. But just you mobilize as much as you want, and if you are able to get it, okay. But not really true sense focus.
Okay.
And Vinay, I wanted to ask you one thing about the focus that we have attempted earlier. Actually,
Yes, sir.
If you look at the conventional papers, in most of the places when they do focus, they put the child on complete paralysis for quite a long time, paralyzed and ventilated. Because if you don't do that, the amount of lengthening that you get is not adequate, is what they say. Maybe is that the reason for which our attempts at Fokker is not as successful as Fokker himself?
Our most of the problem with us in our NICU is the post-operative care for 7 days, sir. Most of the time.
But if that is a care itself is difficult. For example, if you look at the Fokker's original literature, he talks about muscle paralysis. In fact, he paralyzes baby and puts them on ventilator for a long time. I mean, will we be able to do that much?
So the last.
Actually, second case which we did focus, we were able to do it, sir. We ventilated with paralysis for 7 days. And we went in on the 10th day and we could actually re-anastomose, but we had other complications of sepsis.
Okay.
So we could bring it on table at the post-op day 8. We could anastomose it 10 to 8. And the child was on ventilator for 7 days post-operatively. But
But
the
wait, what
issues
happened?
were
Could you manage to salvage the baby?
sir.
Could you manage to salvage the baby?
No, sir.
No, that's what I'm saying. See, some things what has been described in the West, when we try to do sometimes, especially with the juggards that we do, may not really succeed. For example, for gastroscosis and example majors, what I used to do was I tried even putting a bag and all silo types and with blood bank bags and all. But what used to happen is at the end of the 7th day, as you rightly said, we are able to do what we wanted to achieve. But ultimately, we lost the baby of sepsis and other reasons. So that's why I was not too sure how applicable is poker in our
Sir, in our institution, my personal experience, sir, on table focus, if it's slightly under tension, exactly on the clock 10 minutes,
Okay.
see that both the ends of the esophagus are moved
Oh,
almost
okay.
for the anastomosis.
Okay. Good idea.
This
Good
does
one.
not help, then we just go ahead and do a esophagostomy.
Okay. Shoaib, you talked about other things, but you didn't talk much about the transanastomotic feeding tube. And when do you start the oral feeds? I mean, when do you transanastomotic feeds?
So we can start on the next day itself after 24 hours.
Okay. And the one more small technical aspect many of us do is once you open the fistula, I mean, once you ligate and open the fistula, the lower fistula, the moment you look at the lower pouch, which is basically a fistula, is many of us do pass a feeding tube and to decompress the stomach because the amount of air which is inside may be causing distension. So we make sure that we aspirate it before going further.
Yes.
Another question is about the technique of the esophagogram which was shown yesterday by Achyut and which is repeated by you today.
Yes,
What
sir.
is the basic flaw in what has been shown? How do you do an esophagogram to document a H fistula?
Sir,
I mean, if you're suspecting H fistula, how should you be actually doing the esophagogram?
sir, we'll insert nasogastric tube and we'll make the child in prone positions.
Yes.
And we'll insert the dye. And under fluoroscopic videography, we'll start pulling the OG tube and by the same time, we'll instill the contrast. So if there is any fistula, then during this withdrawal of the tube, the dye may go inside the fistula site and delineate the trachea also.
Okay. So it is, what is it called? It's called pull-up esophagogram. Okay.
Yes. Yes.
The technique what was shown yesterday was not the right one. If you're just going to allow the child to swallow and see, the fistula has come. So I think what has been done yesterday was not to look for H fistula, but I think they incidentally picked up a H fistula when you're doing something else. Am I right, Achyut?
Yes, sir. Yes, sir.
So it is
Yes, sir.
not documented, it's not done it deliberately to look for H fistula. Okay. What are the other ways by which you can identify H fistula?
One is with the bronchoscopy or even with the esophagoscopy.
Endoscopy.
Okay, why don't you do esophagoscopy? Because it's a H fistula, no? So there must be a esophageal end also. I would rather do
Yes.
esophagoscopy. Huh?
Yes.
Come again?
Yes, we can start. We can do the esophagoscopy.
Anybody else?
Because of the mucosal folds, we won't be able to make out the fistula as such.
One, correct. Apart from that, anything else? Agreed. Anything else? That is also agreed. The trachea is actually a fairly rigid structure, and you will be able to see the openings much easier as compared to an esophagus. Agreed, which is a collapsed organ and muscular organ, and maybe have little mucosal folds difficult. Any other issue anatomically?
Fistula is anteriorly, it's difficult to see the. It's difficult to see the.
Not a H fistula, it's more like an N, sir. So
Okay, it's like an N fistula. Whereas the proximally, if it is actually in the tracheal end, from tracheal end, it actually goes distally. So it's easier to visualize. Whereas in the esophageal end, actually is coming from above. So when you're going to do it, you have to rotate the scope to see the roof, and to cannulate it is going to be extremely difficult. The only place where how we actually confirm is do a bronchoscopy locate the fistula, put a guide wire or ureteric catheter, and then do esophagoscopy and identify that. Okay, that can be done on table also to see. If in case you identify fistula, which is better, neck or chest?
Neck, sir.
Anybody else?
Because most of the time it is proximal.
Anybody else?
Neck.
See, it's at the very low, what you call lower neck and the upper chest. Okay, so it can be approached by both. Anyway, you're right that most of the times we approach by neck. Is there any advantage or disadvantage of approaching from neck? Okay, if it is open surgery, it is better to go from neck because you will be able to access it. If you're going to do a thoracotomy to reach it, it is almost impossible because it's at the apex. Whereas if you're doing a thoracoscopy, it's much easier because you will be able to visualize it better in the upper end. All right.
Yes.
If I can add a few points regarding diagnostic confirmation of H fistula.
Please. Please, sir. Please go ahead.
Yeah. Contrast study usually, I mean, we all said and do it. Generally, before referral only it will be done. But it has not much meaning, nor I rely on it. But the advantage of if pediatrician they plan to do contrast study before sending us call, I always tell them, you do it and see if there is gastroesophageal reflux. Don't put only small dye so that gastroesophageal reflux is missed, because gastroesophageal reflux is very, very important in managing each type of fistula, post-operative morbidity and problems. That is number one. Number two, while giving contrast study, sometimes if there is associated laryngotracheal cleft, you will see spill over into the area as soon as the dye is given. So it alerts you for one such structural abnormality. Second, that swallowing mechanism is problematic because of, say, neurological issue or some other problem like vocal cord presses, etc. So you are alerted apart from suspicion of H fistula, because H fistula suspicion will come in during these situations only, this clinical situation. So from that point of view, that is okay. Now coming to the bronchoscopic evaluation, it's very nice if we see large wide fistula, your ureteric catheter or any other catheter going through it. But more than 50% of the time, what I have seen, reasonably good number I manage, it is very difficult to introduce that whatever catheter you are going to use, ureteric catheter or Terimo guide wire, the ureteric guide wire, all sort of tubes. Secondly, if the fistula size is very small, it is very difficult to make out whether it is fistula or not. So these are the two situations which I would like to highlight and address. So you confirm or rule out 100%, because a lot of bonus is on you when the patient is referred for you if there is a type of fistula or not. So while taking out bronchoscope, you see for H type of fistula presence or absence. Not while shoving, when you are going inside and seeing. Most likely you are likely to miss because mucosal fold will cover it. So while coming it, you just come very slowly and ask anesthesiologist to give nice positive pressure ventilation. So whatever mucosa thing which is covering up there, which will open up, and the opening also will nicely open up. That is one. Or if the area or the opening is too small, what you will see, just there is some sort of a irregularity in the mucosa. Irregularity in the sense, some sort of a rosette-like appearance or a sort of a channel-like thing or something, but you can't say actually fistula. So spend more time, just come proximal couple of millimeters, spend more time there, ask anesthesiologist to bag, and very nicely sometimes it opens up. Despite all this, if the fistula is real small, mucosal changes are not very appreciable, still there is a possibility of fistula. In that situation, you introduce a little bit of methylene blue and then pack, before introducing methylene blue, you pack your oral cavity so that methylene blue doesn't come back retrograde from the cords and spill over into the esophagus. So once that is taken care of, you take out your bronchoscope and introduce into the esophagus, or simultaneously put both esophagoscope and bronchoscope. If you see bluish color of hue or a nice dye there in the esophagus, that will be confirmatory. And the third, despite all this, if you miss and you want to still finally do it, instead of putting endotracheal tube into the trachea, you put endotracheal tube with a balloon inflated with expected fistula site, okay, where the doubt was there on bronchoscopy. You inflate the balloon, I mean the cuff of the endotracheal tube. Then by the side of the endotracheal tube, you just introduce a small feeding tube, and through that small feeding tube, you introduce methylene blue or even simple small 1 or 2 ml of saline, and then put the scope, bronchoscope into the trachea, and just ask anesthesiologist to give a sort of a bagging there with the endotracheal tube. You will see nice bubbles coming up, bluish color bubble if you have used methylene blue, or even saline bubbles which are coming up through a small fistula, and it will be unmistakably either diagnosed or not diagnosed. So you can very 100% be sure that fistula is there or not, because the onus is too much on us to very correctly give the report.
Excellent points, Raju. Other thing I wanted to ask you was, not you, the rest of the presenters was, is there any endoscopic management of H fistula that has been described or been seen? What are the plus minus? Anybody?
Sir, glue injection, sir.
Yeah. What glue?
Cyanoacrylate.
Cyanoacrylate can be used, or it can be used, even a tissue glue can be used. Okay. So we have attempted, but it is not done generally for a regular H fistula. In fact, what we have done is for a recurrent H fistula, we have, not recurrent H fistula, recurrent tracheo-esophageal fistula, we have done it in a couple of cases. But of course, the advantage is that it's non-invasive. The disadvantage is that it may give up because we don't know how long it stays. So the alternative, what we have done is we have done a bronchoscopy. We have seen the opening. We used a Bugbee electrode to sort of cauterize the mucosa so that epithelialization can happen, and then we have injected the glue. These are few and far between. As I told, it's for a rather than the primary case, it's good for a recurrent case because going inside may be difficult to identify the fistula. Because in a recurrent case, once you go inside a previously operated chest, going inside and again to dissect is going to be difficult. And identification of the fistula is not all that easy that we are talking, because once you go inside, you'll see the trachea and the esophagus sort of plastered to each other, and exact location of the fistula may be difficult to identify. In fact, in the process of dissecting, you may make 1 or 2 holes in which you don't know which is a fistula or not. So especially if it is a recurrent fistula, it is always it is worth considering. I'm not saying it is useful in all cases. At least it is worth considering trying this sort of endoscopic method. Dr. Vinay Jadhav, Vinay Maximus.
Sir, one more point.
Yes, please, Anil.
So like you mentioned, no, so most of the principles of surgery applies to the other places also. Like when you are dissecting esophagus from trachea, you just given the example of anorectal anomalies. See, similarly, this endoscopic method, what you are explaining, like burning with a Bugbee and putting a glue, so it applies to even third or fourth bronchial fistulas also, where the opening is in the vallecula.
Okay.
Just for the PG sake, the extra knowledge, I thought of sharing it.
Especially pyrenofossa fistulas and all, it will be good to do it. Agreed.
Yes.
Agreed.
Yes, you have to always burn it and then put the glue, then the effect will be good. So other thing is the fistula identification and the probable complication has been discussed, sir, now, the regular talk?
I think so.
Okay.
And
Okay,
is
sir, right.
particular point that you want to highlight, you just highlight, please.
The same, sir, like how do you identify the fistula? Not in the H fistula. H fistula we discussed now, the regular fistulas I'm talking about.
Good. Go ahead.
Yeah. The 2 points, like the important structure like aorta and the left bronchus. These are the two, the confusing point, or we may misdiagnose this as fistula and you can ligate it. So you have to be careful about these things. To differentiate the left bronchus, when you about to ligate, always better to ask the anesthetist to auscultate on the left chest to avoid ligating the left bronchus. Regarding the aorta, you need to feel for the pulsation. And again, as Dr. Rajendra sir explained, so you can ask our anesthetist to do that bag and mask, sorry, not bag and mask. So hand ventilation. So you can see the fistula being bloated intermittently to identify it.
Okay.
Thank you.
Fantastic points, Anil, because in KEM hospital, Borunkar sir used to have a very clear policy that whenever you see a fistula, he used to insist on putting a soft bulldog clamp, occluded, as the anesthetist to auscultate on both the sides, because right side will be seen whether it is getting aerated or not. Left side could not be seen, so it was insisted that left side air entry has to be confirmed before ligating it and dividing it. But I used to find it ridiculous. I said, how can you see? But don't worry. One of our own junior staff members, it is better not to tell the names, actually had divided the, what she thought was a fistula was divided, and finally it turned out to be left bronchus. So I had to go inside, and I remember suturing that. The left bronchus was actually transected. So on table, somehow we still managed to retract it and suturing it. So it is not difficult. So it is always worth remembering that there can be complications and to be looking out for them. It's not that you need to get paralyzed, but you should know about these things. Thank you very much, Anil.
Sir, meeting will end in 2 minutes, huh?
Yeah. Vinay Jadhav.
Sir, at KEM, there is still a practice of keeping a stethoscope on the left chest and taping it, sir. And then the patient is draped. So, at the time of fistula ligation, the anesthetist will hear it and then fistula is.
So Vinay Jadhav, you decide whether you want to continue or you want to wind up, because we have sort of hijacked the discussion from you.
No, it's absolutely fine, sir. Whatever other members say, sir.
No, if you have any questions, because I'm through with all my questions, nothing more from my side.
No, sir. I'm done through the presentations.
Ramchandra sir, any concluding remarks?
No, I think it was a very good discussion. I think we should stop now.
Okay, sir. 9:30. Say goodbye. Thank you very much, Shoaib. You did a very good job today. Okay.
Thank you, sir.